Thank you. Thank you very much for the kind introduction. And I'm very grateful for getting this opportunity because cancer is where my heart is. And any opportunity to reach out to people on the Cancer Crusade is something close to my heart. I want to start with one small narration that actually when we were in college and doing our surgical training, the most common cancer surgery was KDB, kholo dekho band karo. The thing was that most of the patients who were taken up for surgery on the table, they had advanced cancer and there were not enough diagnostic mechanism, not enough tools that we could investigate and find out, do an ultrasound or CT or MR. Even these things were not easily available. So invariably a diagnosis was made that there is a cancer and you try to open up and then you find it's an advanced cancer and you close. So what has happened? That the whole opportunity, the time of the patient, the suffering, the professional time, the training, everything got wasted. So it was always haunting me that we are not able to realize our full potential in the delivery of cancer treatment, or for that matter in so many things. If I take even today's practice, so a lot of times in the era when we have the knowledge of targeted therapy and all that, we realize that certain drugs will not work in a given patient. To give an example, if a lady has a small tumor in the breast and it is a tumor is hormone sensitive, even if we give chemotherapy to that person, the advantage is not there. The benefit is only by adding the hormone therapy at the right time. And if you have given chemotherapy, the side effects are there, the cost is there, the suffering is there, so much of time is wasted. So, and similar things in surgery, if you have not done a proper staging workup and you take a patient for theater and then you find inoperable or unresectable, and if that could be sorted out beforehand, all this raises a question in our mind that are we realizing all that we have or utilizing all that we have at our disposal to actually use those resources for optimal delivery of care. And in fact, the other day I was talking to Mrs. Mohini Daljit Singh, who heads our Max India Foundation, about how to allocate our resources in the CSR arm of Max Group, the Max India Foundation, so that we are able to maximally impact the society in a beneficial way. And we realize that most of our allocations go into palliative care and rehab and advanced malignancy. Whereas it's better that we support or we strategize to prevent cancer, to do early diagnosis, because these are the things which have maximal impact on outcome. So we decided that, okay, at least 50% must be spent on this part and remaining 50 we will allocate differently because other areas also need care. So to summarize this part, I would say that in all areas of our work and professional, especially professional work which impact society, we must be aware and cautious that whatever resources we have, how best to use them to have a maximum outcome. Now, if I look at the cancer burden is huge, and it is huge today, but the even more worrying thing is it's going to multiply at least double in the next 20 years. So this is a more worrying part, and this is where we need to actually wake up and take things more seriously than what we have been doing till now. And it is not just the incidence which is on the rise, the mortality is not going down. In fact, if I look at the developing countries still the mortality, more than 60% people who are diagnosed with cancer die because of the cancer. Whereas in the developed world, it's about 70% cure rate. So the difference is so stark that a lot of things we don't have to reinvent. We can leapfrog and apply that information, that technology, that knowledge, and use it widely. Today with the connection of this IT world, what we are having just now, a webinar, I think I had never imagined such a thing even 2 years back. We were... Actually, you want me to do it? Okay, sorry. So, if I say that we are not able to use the IT power, the scientific knowledge, all that optimally, if we put all that to use, probably we can bring down a lot. And if I look at today's data, I would say that today in India, almost 12 to 14 lakh new cancer cases are diagnosed. At any given year, we lose almost 60% of them to cancer. And in 2025, it is projected that this figure will reach somewhere around 20 lakhs. And still the mortality will remain 60% because we are still struggling with early diagnosis. We are not doing enough for prevention of cancer. We are not doing enough for penetration of these resources to our peripheral cities and remote areas. So this is what this talk is all about, that what all we can do to make a difference to the society. Now, let me touch on the first of this chain, the first point of this on this chain, that is the prevention of cancer. We all know 50% of cancer is curable. More than 35% is because of tobacco. And this knowledge is in public domain for good time. It's there at least for the last 20 years and going that we ban tobacco, should we do something, should we educate people more? But always I realize that at the critical time, some such questions get raised which actually carry no weightage, and then the decision is reversed or stalled. The point is that if we all know there's enough evidence that what are we doing to stop this cancer menace, tobacco menace, and to work in favor of people's health. The second part we all know is the lifestyle impact. The kind of diet we have, the exercise we are doing, because this diet, healthy diet, which is the green leafy vegetables or fruits and having enough helpings per day so that you ensure that your non-vegetarian diet or lack of fiber is not so much in the diet is being taken care of. So these things are possible. Instead of opening more hospitals, the government can also consider opening few of these educational centers on prevention of or empowering people on improvement on health, creating maybe yoga centers, maybe sports complexes for people's use, or very simple educational format things where you have just health education 24 hours or maybe 12 hours a day. Different walks of people will come and go, and they will empower. I'm sure if as people will be exposed to more and more of this, more than 50% will use it, which I feel that we all can work without putting too much of money and resources, and we can make a big difference. This is just using the knowledge available in the domain of prevention of cancer, and we can bring down the incidence of cancer. We also know as cancer is somehow causes much more anxiety than even other killer diseases like cardiac events, neurological events, and strokes and other things. And the negative part is that this anxiety leads to more ad hoc decision making, more reactionary approach. At the same time, I see some power in that anxiety, because once people get over this treatment of cancer, that is why in cancer you would see so many support group formations, so many people come together, they want to give back to society. So the negative part of this anxiety is in the first half of treatment, when person is undergoing treatment, causes unnecessary stress and sometimes poor decision making. At the same time, the advantage is that this same group, when from a victim they become a victor, they get over this cancer challenge, then they want to support others, they want to come out and support. In fact, I must mention here that in our MAX group itself, we have more than 300 cancer survivors who support other patients and want to help them in this cancer crusade. So this is something which is possible by using just the available information, available knowledge, and available time with educated people who have gone through the journey. You can just connect these dots without putting any penny on it. You can connect and miss time. Then we come to the cost of treatment. As I mentioned earlier, that the era when we used to do this surgery, kholo dekho band karo, the KDB, the cost was huge because of the wastage of resources. However, the tools were much more cheaper and they were not that expensive. Having said that, today the tools are expensive, but even in that time, if we use all this optimally, I'm sure that the cost will not be so much. Here I want to emphasize the availability of these tools and the knowledge. How can it be put to best use? There I want to say that the general practitioners or the primary care physicians, there the key lies. I want to say that all of us are stakeholders and responsible for bringing me to you and people like me to you and educate the whole world. Doctors are responsible because it's our job, and as oncologists, it's my prime job to ensure that we win this war against cancer. At the same time, the civil society has to facilitate all these things, use the right information. So I want to say that there should be modules in the primary care physicians' clinics where they don't differentiate between a suspicious cancer than something which is glaring in your face. When I was in college, one of my professors used to say that today people can diagnose cancer only when even the last person, when the ulcer is foul and swelling, only then they suspect of cancer, not when the symptoms are vague. Now, if we create such mechanisms or tools on IT which are easily accessible, where people can actually get empowered, something like 3 questions, and it's just a matter of putting into practice. So I've had some dialogue on that with Indian Medical Association and other groups, where it is very much doable. And I'm sure we'll come up with some good solution in that. Because if this shifts 70, 40, 50, then the whole game will change. We'll get 70% people get cured. If we pick up cancer early, we'll also give the same results. I'm quite sure about it. I want to also mention here about the retinoblastoma story. There's a mobile app created by our IT expert whose child had suffered through. They have done, it's a very simple tool where they click a picture of all those all children who undergo a polio drop campaign just at birth or something like that, and that app facilitates checking that picture against the retinoblastoma checklist. And if that is free, then you know that this child will not suffer from retinoblastoma. Whereas there's a problem, you raise an alert, you have in the app itself, you have a link, you connect to the link and you are educated on that further. So this is almost zero price, so simple to use. So this is what I want to emphasize, that such things we need to create in the cancer world to make the life of our patients simpler, to make it possible for us to diagnose cancer early so that we can win this war on cancer. And the power of support group and the advocacy group is critical, because that impacts policy making, it impacts the strategy in the hospital, that what is best for the patient, they have a voice there. So we are not using their journey adequately to optimally utilize our own resources. Now, you may be aware of the Herceptin story, that how a nurse was being treated with cancer, for breast cancer in advanced stages, and her tumor was sensitive to this oncozyme called HER2/neu. Hospital and the support group, they raised an alarm that there was a trial going on and the drug was not yet approved for usage. The power of the advocacy group, the FDA had to give approval and it was used finally, though that late. But the outcome was that subsequently the strategy of multi-institutional trials and all this gained more ground. And today it is possible to, or rather it is desirable, to conduct trials across institutions, across countries, and check our knowledge for our patients, so that we are able to do these trials in shorter time, learn from them faster, and make use of that knowledge as soon as possible for the benefit of our patients. So that is very critical. Now, the third important component is, how do we ensure that the knowledge available is getting optimally used by our doctors? How do we ensure that the patients are getting standard of care in the treatment? And how do we ensure that there is a possibility of continuous learning for our doctors? Like what I did 30 years back in medical college, I am hardly practicing any part of that, because the world has changed so much, the knowledge has changed so much. So we need to connect all these arms of our society and then do it. There I will give the example of Khan Academy, which is using the power of IT for education space in the primary education space. Now, similar modules or standardizing procedures are possible to create and use for the larger good of the society, and this will help in continuous upgradation. So today we have CME accreditation points by the MCI in certain states. It's not there in all the states, and such things can be made online, simpler, and to execute, and much more easy to monitor also. And once you're able to do that, I'm sure that we'll benefit the society by standardizing the outcomes, standardizing the training, making sure that people at large are able to upgrade their knowledge from time to time. Now, this also is critical through use of IT by sharing our problems, working together to find solutions. Today, if I have a difficult patient or a situation or a complex clinical situation and don't have a solution to that, it's much more easier for me to tap that information, share with my colleagues, and somebody may experience which can impact the outcome here. So those things are not so widely used, which I'm sure are of immense value and should be used. Now, if I look at the journey of a cancer patient from prevention of cancer to early diagnosis, of connecting with the primary care physicians to empower them, make use of them. If you look at all these points, there's hardly any cost involved. This is all available resource. It is a difference between a smile and a frown. The same face, if you smile, you make a world of difference. If you frown, you again create negativity and world of difference. So point is that the same resources can be used in a manner that have a positive impact on the society. And if we go on from execution of our resources in terms of diagnostic tools, if we say that, okay, if we have 25,000 breast cancer patients in Delhi in a year, how many of these patients will require PET CTs or CT scan or ultrasound or X-ray or a bone scan? And we optimally, the government can actually work on these areas to make sure that everybody gets diagnosed in time, staged at time, and then the treatment can be minimally supported through other sectors. This is much more simpler. In fact, Rotary is trying to set up a cancer detection clinic in Palwal, where I worked on this project. So the idea is that there we'll put in something like 30 lakhs of rupees worth of equipment, infrastructure, but hope that this will be able to cut down the cost of expensive cancer treatment by early diagnosis in almost 2 lakh population in that city and maybe a draining village population around that area. So all this is just by allocating resources in the right place and using them well. Then I want to touch upon palliation. Now, it's very unfortunate that this is one important area of a cancer patient's journey as in advanced cancer especially, which is hugely neglected by clinicians, by all of us. We are to be blamed for it. And we do not have focused palliative care physicians. The oncologists do not have time for palliation, clinical part of changes. And such modules can be possible online. It can be provided on the web because all you need is right use of morphine, right use of painkiller, pain management, and maybe somebody to talk to the patient, and empathetic conversation with the caregivers. They also go through tremendous trauma. There is no structure, no model in place which ensures that we are able to provide them or cater to them answers to their basic questions, these frequently asked questions. If we provide those answers to the caregivers, probably they will be more comforted, and that will help us all in this war against cancer. So as far as the different aspects of cancer treatment are concerned, this is critical. I want to touch upon what National Cancer Grid is doing, because this is one very good initiative from Tata Memorial Hospital, which is helping us, all the oncology centers in the country, connect by creating uniform standards and protocol for patient care across the country. We are also able to pool in our data so that in this country we'll have good data pooling and then do trials and know exactly how our patients are responding to these treatments. This also augments the human resource capability in cancer management by exchange of knowledge and by expertise and mentoring the young colleagues who are coming in, and the promoting the collaborative research, as I mentioned. This also enables creation of cancer policies. Now, all this knowledge, if we use optimally, maybe the policy making would impact prevention and early diagnosis much more, and maybe even take care of the treatment part in a much more simpler way. There's urgent need to formulate a dedicated policy on cancer screening. I know it is screening is something which is only accessible to maybe 3-4% of our society. Not today, it is possible to screen almost 50% of cancers. For our challenge in our part of the world is oral cancers, breast cancer, cervical cancer, lung cancer, and breast and cervical are definitely screenable. Just a one-time, lifetime screening by pap smear can bring down the cervical cancer by 25%. These are very simple, low-hanging fruits which we are not working upon. If we just connect all this and make a difference, it will bring down mortality at very limited cost. The use of target therapies and personalized medicine, which has huge potential for treatment in cancer, is again, because of the cost, prohibitive cost, is beyond the reach of majority of our patients. But as we all know that we can work with our technology, as we've done the far expensive drugs in US are at much cheaper price here because of the biosimilars. Similar things can be worked here as well and bring down the cost, which I'm sure our scientists are doing on that. The modern diagnostic and therapeutic tools can be provided at faraway places so that we are able to diagnose and treat them early. So all in all, I want to say that the resources which we have in terms of knowledge, in terms of simple technology which can make a difference in outcome, and the power to connect and use our oncologists in a manner so that we are able to network with the large physician community and the society at large to bring down the cancer mortality. Thank you very much. Questions. Click here. Questions. Okay. Just click. Questions.
Enlarge this, drag out. So without the name of the person also, because they are not able to see the questions.
Okay.
Question and name.
Okay. So there is one question from Shahid Akhtar. PM envisions a screening center in every district. To what extent this will help? And pardon?
Show my webcam.
Mr. Shahid, this is a wonderful question. This is the first part of what I was trying to emphasize, that prevention and early diagnosis. I would say instead of calling them screening center, let us call them prevention, because prevention is 50% of this cancer load can be cut down just by preventing cancer. And you can imagine if the load of cancer comes down 50%, you can use the same resources for the remaining 50% in a much more stronger way. So that is where more than screening, I would say prevention and early diagnosis. That is what I talked to the Rotary Club also, that they should, instead of calling it screening, let us work on prevention and early diagnosis. And early diagnosis, I'm saying, because this is another area which needs good work, because few cancers are not preventable. Cannot be screened, but they can be diagnosed early if we educate the people that any symptom beyond 2 or 3 weeks should be ruled out for cancer. These things are very important. Does it answer your question? This will impact the society in a big way.
Do we have the resources?
So we have the resources for screening. See, all that it requires as of today, every city district has a hospital, every district has we have doctors who are sitting there or doing their work from morning to evening. We need to create a module and use IT for prevention and early diagnosis. We just need to empower people. All the hospitals are centers for treatment. Instead of that, if we create a small room there for education, health education, and for early diagnosis. Even if you don't have cancer, please come here, we will educate you on cancer. We create some modules, CDs, and give them this information. And also that there are certain alarms. If you have any of these things, any symptom for more than 3 weeks, you come here, one of the doctors will work on it. Next question is how to diagnose whether a person is having a cancer or not. Mr. N. Hanumant Rao has asked this question. So this is easy and difficult. Now this question is easy and difficult. Now easy because cancer diagnosis is only made on biopsy. So I have a one-line answer. The diagnosis of cancer is made only on biopsy. And this is important because the moment we say a biopsy is done, their reaction is, we don't want any knife spreads cancer. So that is not true. It doesn't spread by that. By not doing anything, waiting and watching, it spreads. So the answer is that a biopsy is critical. Now the second part is that rather more important or hidden in this question is that is this cancer, when do you suspect cancer, or when you do biopsy for cancer? So for that, the clinical context is very important. Now, for example, let me take the example of an oral ulcer. If I have an oral ulcer for 3 days, which is painful and tender, then I know that this is an aphthous ulcer and this does not need a biopsy. But if somebody has an oral ulcer for 3 weeks, and there's minimal pain or no pain, and there's minimal induration, and if he's a smoker, if he's a tobacco user, if he's an user alcohol off and on, then that same ulcer will need a biopsy. So the issue is that biopsy is the way, but when to suspect and when to take a sample is also important. I want to add a word of caution here, that even if the suspicion is low, but one is not sure, it is better to biopsy it than to lose that opportunity. Quite often it so happens, for example, a breast lump. The lady has an ultrasound or a diagnosis ultrasound, and the diagnosis made is fibroadenoma or a benign disease or nothing picked up, or a mammogram not picked up. So what happens, you get reassured, and then for next 1 year you don't do anything, no biopsy is done, and that leads to delay in diagnosis. We must know that almost 30% of cancers are not picked up on mammogram. Likewise on abdominal symptoms and all that. So whenever suspicion is there, minimal suspicion, must do a biopsy, especially if the symptom is there for more than 3 weeks. Is cancer caused by stress? By Mr. Abhishek Kumar asked. So there is no direct evidence to say that stress causes cancer, but we all understand as oncologists and as doctors that stress weakens our immune system. And when the immune system gets weakened, then all these insults on the body, all these factors which cause disease, they dominate. And then the tumor host balance gets tilted towards the tumor, and the tumor dominates and manifests itself as cancer or things like that. So there's no direct evidence. There is some evidence, for example, that those who do yoga tolerate chemotherapy better, those who have a healthy lifestyle, they are able to cope or get more cancer-free period and things like that. So I would say that yes, stress does harm and indirectly causes cancer. Your suggestion to enhance and improve palliative care, we are not able to resource morphine as yet. Exactly, this is what I was trying to emphasize, that palliative care is somehow been beyond the reach or beyond the focus of the oncologist community as well. Most of our cancer centers are also very ill-equipped on this very simple, very cheap drug which should be used. So I can only say that it is very critical. Fortunately, the Parliament in the last session, 2 sessions back, has cleared this bill on morphine. So I'm hoping that this will get further empowered and things will happen. Now, whether exclusive diagnosis centers in big cities like Chennai, Bangalore, to diagnose cancer. Okay. So I think this is also a very good question. That this is something which I believe in, that we focus too much on the treatment part as far as resources are concerned, and we do not subsidize or support early diagnosis or healthy lifestyle or empowering people at that level. So I want to say that diagnostic centers created by the government to just help in facilitating diagnosis. There I mean not just X-ray, ultrasound. It should be CT scan, it should be endoscopic facilities, it should be good clinical examination facility. So a person who has, and there's no treatment facility there. The focus is only and only on diagnosis. So you will collect so much of data and you will correct your process so well that finally we'll end up having better strategies for our patients. What are the side effects of cancer treatment? By Abhishek Kumar. So depending on the treatment, the side effects, for example, if I talk of radiation treatment, it causes certain skin discoloration in that part, loss of hair in that part, and sometimes fibrosis. But having said that, one must realize that this is all localized treatment side effects, and generally patients do very well. Likewise, chemotherapy causes hair loss temporarily and causes neutropenia or lack of blood cells in the blood, so that during that period the person is prone for infections. Surgery, for example, a breast surgery may expose one for lymphedema. Oral surgery may cause difficulty in chewing and things like that. So every area has certain side effects. So depending on the area where the treatment has been done, and also depending on the type of treatment, the side effects will matter. Can you tell us something about personalized cancer care that we hear about so much these days? We are practicing this at Max. Yeah, are you ready? So answer is yes. Today all major cancer centers in the country are there and doing personalized cancer care, and this actually emphasizes on understanding the signature of the cancer. That is, every cancer is in certain ways unique. There are some certain tumor markers, certain oncogenes, certain modifications at genetic level, which blocks certain type of treatment. So you know that if you have this gene, then this chemotherapy drug will not work, or this particular simpler treatment will work. So these are all possible. We have a personalized cancer care clinic because Dr. Amit Verma in our hospital, he specializes in molecular oncology and personalized cancer care. So there he helps in identifying exactly the kind of treatment which will help in these patients. So today it is applicable in about 5 to 7% of our patients. Large majority of patients are still treated by the traditional methods because that is what where the solution lies. So how does my doctor decide which chemotherapy drugs to use? By Mr. Abhishek. So here every treatment, depending on the organ, the type of cancer, treatment protocol, standard treatment protocol includes the drugs and the dosage and everything. So this is which is to be followed without in letter and in spirit. There's NCCN guidelines are one good example. Every society has its guidelines where they try to collate all data and standardize these procedures. And it is best to use such things so that you are sure experimental or stupid is a standard of care. However, when the treatment fails or relapse happens, then there's more vagueness and uncertainty what is working and not working. So except for few areas, large majority of areas where the treatment fails, then we work upon having using by own experience, by knowledge, and by sharing knowledge. For example, in our team, we have a mechanism process of tumor board. All patients are discussed there. So there, the medical oncologist group of 5-6 people will actually discuss, this has not worked, what more. So they share their knowledge and take a decision. How can we avoid being affected by cancer with the GMO food solid on sold on market these days without any label? GMO is okay. So actually I don't have much idea about this. I can only say that available in public domain, the information. If anything has come out, at how it is impacting. But generally speaking, food is something which we are not focusing so much, but we should focus. So other than tobacco, other than too much of spices or a lack of vegetables in diet, other things are not so well understood. So I am not fully aware of this. Please let us know the screening test to get the symptoms of any kind of development in body. Like for smokers, should go to the following test and losing fat. Very, very good question. So screening tests, few are standard screening tests. For example, a mammogram for a lady above 40 years of age. A pap smear test is a standard screening test for all women, married women. Every 2 to 3 years, they should have a pap smear screening. And if it's all right for 15 years, and then besides this, a prostate-specific antigen for prostate cancer is a screening tool and useful. And not for screening, but for monitoring purpose, you have CA125, CEA, certain other simpler markers. But if I talk about screening, I would say if you are a smoker and above 40, then if you have a cough or anything else, still there's a reason to get a CT scan done, because CT will help us in picking up early cancer. Even X-ray is not good enough for that. There are a lot of studies going on low-dose CT scan screening for smokers. So this is something which will get standardized very soon. Likewise, in our practice, what we realize that people who chew tobacco, they should have regular examination of the oral cavity. That simple tool will help us in bringing down the making early diagnosis possible. Other than that, I just mentioned about retinoblastoma, how a simple mobile app is being used as a screening tool for detection of retinoblastoma. So generally speaking, depending on the load of cancer in a society, a screening mechanism is evolved. For example, in Japan, gastric cancer is number 1. So there they do screening for gastric cancer by endoscopy and by double contrast barium swallow. So all this depends in our society what is relevant: mammogram, pap smear, PSA, oral examination, and for smokers, maybe low-dose CT scan after the age of 40 years, especially for those who have got vague symptoms. Whether a biopsy can be done every year like medical checkup for sugar, BP, etc. No, so it's important to realize that biopsy is for a specific lesion. So unless you have something to biopsy, there's no biopsy to be done. So biopsy per se is not an answer. So it is generally a screening, and you pick up something. If there's something suspicious, you must biopsy. Not suspicious, vague, but there for more than 3 weeks, still biopsy. I would rather go for biopsy than to wait and watch, because wait and watch leads to problem. How can we avoid the potential risk of cancer caused by GMO food we consume these days? This is something I really don't know. GMO food, genetically modified, I don't know much. Potential risk of cancer.
How about this insecticides, pesticides?
Okay, so insecticide, so organic food is something which is being talked about and is in. So the information about insecticides all is not so well known. What we do know, however, that this Harit Kranti jo hui thi, the green revolution which happened in Punjab in the 60s and 70s and led to making India independent in grains and certain areas by widespread use of insecticides and pesticides and manures and things like that. But there, certain types of cancers have gone up in Punjab, like liver and abdominal cancers. So one of the theories is that probably that has led to this impact gradually when this food is being widely used. But we don't have solid data on this. Cancer treatment involves a lot of money. How to prevent the same by diagnosing at earlier stages. So this was actually my focus of my talk, that early diagnosis leads to much less cost, much less suffering, and much better outcome. Okay. Do I see that question again? Okay, I'll find it. That was the last question. And that was about the data. How are we using the data? The question was, how are we? So,
how data has impacted oncology, or is it too early to ask and expect? How do you see things evolving and future hope? So I am very sure, but see, whatever we have seen in last 60, 70 years, since 1950s, when statistics started playing a critical role in decision making on what is working and not working. Since that time, the realization that data is critical for success has happened. And today, no drug comes into public domain, no strategy comes in unless it is tested against data. There's strong evidence to say that this actually works in more people than what was working earlier. So that is absolutely basic. Now, as I see things evolving, I see better connectivity. The same trial which earlier used to take 10 years to recruit X number of patients so as to make good statistical data for a clear-cut decision making. Today, by connectivity of few centers, it can happen in from 10 years to 5 years or 4 years. I see this happening much faster and can come down to 2 or 3 years, because once you are able to recruit patients faster, you are able to take decisions and apply this knowledge in a much faster way. So my future hope is that we will be able to use our resources optimally as we connect and talk and make people believe that these are simple, low-hanging fruits, and a lot is possible without investing too much of money. One strategy is just keep pumping money without thoughtlessly. Other is whatever we have, put thought behind it and then apply that money. And with that same resources, with simple thought thinking, we can actually create better strategies and improve the outcome.
We have also received a couple of questions from people in social media.
Okay.
So we request you to take a couple of questions. This question has been asked by Rahul from Indore. The question is, where does India stand in cancer map of the world?
So where does India stand on cancer map in the world in terms of incidence, in terms of treatment outcomes? So I'll give you different perspective on the same question. So one is that our cancer load, fortunately, compared to the US, the incidence is about 1/3, just by sheer number of population. What I mean by that, that in India the incidence is about 120. If I talk about the incidence in India, it's about 120 new cases per lakh per year. Okay, where same thing in US is about 430 or 440. So the incidence is only 1/3, but the population is so big that even that beats us in numbers. So finally, if I have to say that in terms of volumes, this is where we stand. In terms of treatment options, in big metros and big hospitals and all these places, people have access to decent cancer care. But if you just go 50, 70 miles beyond the metros, नहीं चल रहा है. So if we go 50, 70 miles outside metros, the facilities start deteriorating exponentially, and you have very limited resources and facilities available for treatment. So you have to go a long way. We have to catch up with a lot of easy things which we can do at much lesser cost. Thank you. Thank you very much for this opportunity. Thank you.